with our research will moderate this particular session. So Ron, please.
Thank you very much, Bruce. And that was a really great session. I enjoyed it so much. Yeah, so here's an update regarding countries in DOPPS 7. We have 17 countries, 423 sites, and nearly 12,000 patients in the US, Europe, GCC, and in Japan and China. See here. Oh, next slide, please. Yeah, thanks. You know, our study in DOPPS really could not be possible without the great leadership from our country investigators. You know, each of the countries adopts right from the very beginning, and so we just wanted to again to call attention and thank our country investigators for all of your contributions to DOPPS. You play such an important role in leading the study within each country and providing such important and key feedback regarding dialysis care in your country. And this last session, I think, is just a really good example of that. All of the new information that's coming out and the different perspectives that you provide. So just want to really highlight the important role and our great thanks to all of our country investigators who play such an important role. Also, in the last couple of years or so on, we've increased our efforts to have DOPPS data analyzed by data hubs, where there is expertise in carrying out epidemiologic kinds of analyses and the statistical kinds of expertise that one needs. And right now, with regards to DOPPS data, we have 3 such hubs. One is in Canada, based at the Ottawa Hospital Research Institute, led by Dr. Manish Sood, who's a country investigator from Canada, and in China at Dr. Li Zhuo's place at Peking University People's Hospital, and in Japan at iHope International, which is based in Kyoto, in close collaboration with the JDOP Steering Committee. We also have a couple of analytic projects going on where we've provided data for those, and one of those is on community racial composition and outcomes, led by Dr. Laden Golestana from Montefiore Hospital in New York, and the other is a study of comparative effectiveness of beta blockers being led by Dr. Manish Sood in Ottawa. Next slide, please. So we have 3 really great, very interesting talks for this session. And the first one will be given by Dr. Angelo Caraboyas, who's a great colleague at Arbor Research. And Angelo is one of our research scientists and does such an excellent job in leading so many projects. And so Angelo, is going to speak today on comparing MBD management using Etel-calcetide compared to cinacalcet, particularly PTH control. Thank you.
Hi, I'm Angelo Caraboyas. I'm a research scientist with the DOPPS team, and I'll be speaking today on real-world effectiveness of Etel-calcetide versus cinacalcet in US dialysis patients using a facility calcimimetic preference approach. So first, some background. Secondary hyperparathyroidism is common in US dialysis patients. PTH levels greater than 600 have been associated with mortality in prior observational studies. Calcimimetics are often used to control high PTH levels. There's essentially 2 options. Oral cinacalcet is susceptible to challenges of self-management and adherence, whereas IV Etel-calcetide has been shown to be superior to cinacalcet in a randomized trial setting, but real-world comparative effectiveness is yet unknown. So some US dialysis facilities switched from cinacalcet to Etel-calcetide as the primary calcimimetic therapy after Etel-calcetide was introduced in 2017. So what we did was leverage this variation in facility calcimimetic preference to compare PTH control in those facilities that transition patients to etel-calcitide, which we call Etel-first facilities, versus those that continue to use cinacalcet as the primary calcimimetic therapy, which we considered to be Cina-first facilities. We used US DOPPS data, and for the exposure, we considered facilities to be Etel-first if they treated over 75% of their calcimimetic users with etel-calcitide, Cina-first if they treated over 75% of their calcimimetic users with cinacalcet. Those in the middle, in that gray area, were considered to be no clear preference. And then we also excluded patients with very low calcimimetic use overall. Our primary outcome was PTH, but we also looked at albumin-corrected calcium and serum phosphorus levels. We took two different approaches here. One was a between facility, a cross-sectional comparison, where we looked at facility calcimimetic preference, which we defined in 2019, and then looked at PTH levels in the subsequent 6 months. We compared those PTH levels in the Etel-first versus Cina-first facilities. But we also took a more longitudinal approach, a within facility pre-post comparison. And we looked at HD facilities during two periods. The first during 2016, when all facilities were Cina-first before etel-calcitide had been introduced, and then also in 2019 after the introduction of etel-calcitide. And we looked at PTH levels assessed after the exposure period in 2016, and then after the exposure period in 2019. And we looked at the pre-post differences in PTH for switch to etel facilities and remain Cina-first facilities. Essentially, did PTH levels change in those facilities that switched over to etel-calcitide? And then we use the facilities that did not switch over as a comparison group to perform our difference in differences approach. This figure shows the temporal trends in facility calcimimetic type from 2017 through February of 2020. What you see at the beginning here is that all of these facilities are orange. This represents 100% cinacalcet, with the denominator being all patients prescribed a calcimimetic. You can see the uptake of etel-calcitide in 2017 and starting to become more common in 2018 into 2019. You see these blue HD facilities. These are the centers who now prescribe etel-calcitide to all or the great majority of their calcimimetic users. And then the orange, dark orange being still 100% cinacalcet, light orange being mostly cinacalcet. So you can see our comparison of interest here between essentially the blue facilities versus the orange facilities. The gray facilities in the middle represent those who had between 25 and 75% mix of etel-calcitide and cinacalcet. They had no clear facility preference. And so inclusion of these centers would likely bias our results by indication if the decision to prescribe patients etel-calcitide versus cinacalcet was mostly based on patient indication and not on facility preference. And then the facilities on the bottom, you can see, had very low calcimimetic use overall, so they were also excluded. Table 1, we show patient and facility characteristics for Cina-first and etel-first facilities. You can see that the major difference here is what jumps out is dialysis organization size. And you can see that the Cina-first facilities are mostly the LDO, MDO, the large and medium dialysis sized organizations, whereas those that switched to etel-first tended to be more the small dialysis organizations and independent facilities. You can see also other differences in practices, including more calcimimetic use overall. in the Etel-first facilities, and also less active vitamin D use overall in those facilities. Patient characteristics, the Etel-first facilities had patients that were a little older, and other small differences that largely were a product of the difference in dialysis organization size. Here's our approach 1 results. This is the cross-sectional analysis. So you can see that comparing the 45 Etel-first versus 67 Cina-first facilities, when we looked at the calcimimetic users in those facilities, the users in the Etel-first facilities had much lower PTH levels. You can see 479 versus 715 in terms of the mean. There was quite a bit of differences in those patient characteristics that we observed in the prior table. Once we accounted for those, the adjusted difference between them was about 115. Similarly, when we looked at the proportion of patients with PTH greater than 600, the proportion was 44% in Cina-first facilities versus only 21% in Etel-first facilities. Once we accounted for differences, the difference was a little smaller, but it was still an effect size of adjusted difference of 11% between the 2 facility types. When we looked at calcium and phosphorus, we saw much lower effect sizes, if any. When we looked at the longitudinal approach, approach 2, what we see here, when we compared 32 facilities that switched from Cina-first to Etel-first, and looked at 34 facilities that remained Cina-first from 2016-17 all the way through 2019-2020. When we looked at the calcimimetic users in the switch to Etel-first facilities, you can see PTH levels in those facilities decline quite substantially from 671 down to 484, whereas in the facilities that did not switch over, their mean PTH levels slightly increased from 632 to 698. Once we accounted for differences in characteristics, the adjusted difference was in mean PTH was 169 lower for the switch to Etel-first facilities. Similarly, for PTH greater than 600, the proportion decreased substantially within those centers that switched over. That dropped from almost in half, from 40% to 20%, whereas the proportion over 600 remained around 40% in the Cina-first facilities, with an adjusted difference of about 14%. Again, you see calcium levels slightly decreased. The proportion with calcium less than 8.4 slightly increased, but certainly not to the extent that we observe for PTH. So to summarize, we leverage variation in US HD facility practice to conduct this sort of natural experiment. Following introduction of etel-calcitide in 2017, we isolated those facilities with a clear calcimimetic preference so that whichever drug each patient was getting was more likely determined by the facility preference and not by patient indication. We observed better PTH control in those facilities that switched over their calcimimetic prescriptions to etel-calcitide versus those that continued to use cinacalcet as the primary calcimimetic therapy. Calcium levels were slightly lower in the Etel-first facilities, and phosphorus levels didn't seem to be associated with facility calcimimetic preference. So despite advantages in efficacy shown in trials, in real world effectiveness shown here, etel-calcitide use does remain limited, largely due to the cost environment in the US. Though we looked at MBD markers and levels here, but note that further research is needed to investigate the impact on clinical outcomes. Thank you.
Thank you very much, Angelo. It's really an excellent presentation. And I just want to remind folks that if you have any questions, to please submit them using the Q&A feature on your screen, and we'll try to address questions near the after the end of the session, after all three speakers have had a chance to present. So our next presentation is by Dr. Pablo Urena, who is one of our country investigators from France. And actually, this is part of a project that is with our DOPPS investigators. Every year we try to carry out a research project, and this is one of those projects that was selected. And so, Pablo, thank you very much for giving us a presentation today, which we're really looking forward to. Thank you.
Hello, ladies and gentlemen. I'm Pablo Antonio Urena Torres. I am working as the Chief of Dialysis Service at the Aura in Saint-Ouen, Paris, France. Together with Professor Christian Combe and Fitsum Gebre, we are the principal investigator for DOPPS in France. Before starting, I would like to thank the DOPPS team, in particular Angelo Caraboyas and others, for allowing us, Naïde Tabizadeh and myself, to do this study. The study title is The Diuretic Prescription and Incident Hemodialysis Patients International Practice Pattern. As you know, there is not too much data regarding the use and the dosage of diuretics in chronic hemodialysis patients. And in some of the already published studies, it has been suggested that the continuation of diuretics in this patient could reduce the risk of hospitalization and mortality. To get more information and probably to help better inform international therapeutic strategies, we'll here investigate the regional variation in the loop diuretic use and dosing strategies in association with clinical and dialysis-related outcome. We here present the very preliminary descriptive data of the DOPPS cohort analysis. For that, we examined the DOPPS cohort, which included more than 7,000 patients during the DOPPS phase 2 to 5 from 2002 to 2015. That group of patients included 27,759 patients with a dialysis vintage less than 1 year, what we call the incident dialysis patients. Then the parameters we analyzed were the following: diuretics use, yes or not, according to the dialysis vintage; diuretics, yes or not, regarding the type of diuretics among the incident dialysis patients; the percentage of diuretic use by facility in the same patients. That was restricted to the facility with more than 5 eligible patients. And then, because there were several types of loop of diuretics, we converted the 20 milligram of torsemide equal to 80 milligram of torsemide, and 1 milligram of butamide equal to 20 torsemide or 20 milligram of torsemide. You can see here that the most frequent type of diuretic used among the country was the loop diuretics, 95 and 96%. Only 3 to 4% of these patients were using other type of diuretics. Now, this slide shows you the evolution of the patient or the percentage of patients taking diuretics during the first 5 years of dialysis. And you can see that the percentage of patients decreased constantly and progressively from the first year to the 5 years of dialysis. For example, here in Germany, in the black line, you see that it goes from 85% at the beginning to less than 40% after 5 years of dialysis. It was the same for the other countries, like here in France too. Also in Italy, from 60% to 20%, and even in countries using less than 30% of dialysis, were taking diuretic at the beginning, and only 5% were taking after 5 years of dialysis. Next, this slide illustrates the large variation in the use of diuretics within country. 70 to 80% of patients in Germany and Sweden were taking diuretics during the first year of dialysis. 60 to 30% in Belgium, Canada, France, Japan, and only or less than 20% in countries like the country of the Gulf, Spain, UK, USA. There was also a large variation in the doses of diuretics within country. You see here that the mean doses of diuretics in Germany and Sweden was around 500 milligrams a day. That in United States, UK, Canada, and other countries, the dose was lower than 200 milligrams a day. So we can say that there is a substantial international variation in the diuretic prescription practices among incident dialysis patients. The next steps we are planning to do is to explore association between the diuretic use, doses, and the volume parameters like blood pressure medications, the weight gain, the residual urine volume, and also the clinical outcomes like hospitalization, mortality, MACE, heart failure, the incidence of fracture. We are also planning to collect the ePROs, the physical and mental scores, the vitality energy, the recovery time from each hemodialysis session. We are also planning to look at the bone and mineral disorder markers like calcemia, phosphatemia, PTH, total alkaline phosphatase, and also changes in the electrolyte disorders like bicarbonate, sodium, and potassium. We are expecting to get the preliminary result in the first Q1 2022. Thank you very much for your attention, and I will be delighted taking questions.
Thank you very much, Pablo. This is a really interesting presentation, and boy, the variation across countries and facilities is really amazing. So now we'll progress to our third presentation in this session, and this one is being given by Dr. Nidhi Sukul of the University of Michigan, who is a great colleague who we've worked with on many projects in DOPPS, and particularly with regards to pruritus, which is such a difficult symptom experienced by many hemodialysis patients. And so here's this presentation on some recent work on pruritus by Dr. Sukul. Thank you very much, Nidhi.
Hello, I'm Nidhi Sukul, a clinical nephrologist at the University of Michigan, and welcome to an update on self-reported pruritus in hemodialysis patients, associations with outcomes and course of symptoms over 12 months. To begin, I'd like to take you through DOPPS's recent publication titled Self-Reported Pruritus and Clinical Dialysis-Related and Patient-Reported Outcomes in Hemodialysis Patients, which was published in Kidney Medicine in 2020. It has previously been shown that chronic kidney disease-associated pruritus has far-reaching effects on the lives of patients on hemodialysis. But information regarding the relationship between pruritus and several key outcomes in HD patients remains limited. So we sought out to investigate associations of pruritus severity with mortality and hospitalization, withdrawal from dialysis, missed dialysis treatments, recovery time from a dialysis session, health-related quality of life measures, and employment status. In this study, over 23,000 patients on hemodialysis in DOPPS phases 4 through 6 were included and answered a single itch-related question from the KDQOL 36, which asked, during the past 4 weeks, to what extent were you bothered by itchy skin? with response options including not at all, somewhat, moderately, very much, or extremely. As stated in the previous slide, we investigated the association of pruritus severity with clinical outcomes, dialysis-related outcomes, and patient-reported outcomes. This figure demonstrates the prevalence of CKD-AP internationally, displaying the distribution of pruritus prevalence and severity here among many countries. Looking at moderate to extreme pruritus, which is the green section down, we see that the prevalence was notably highest in the United Kingdom at 47% and lowest in Germany at 27%. And when we looked at the outcome of mortality, we saw that extreme pruritus was associated with higher hazard of all-cause and cause-specific mortality. Compared to patients who reported being not at all bothered by itchy skin, patients who were extremely bothered had a nearly 25% higher rate of all-cause mortality. Patients extremely bothered by itching also had nearly a 30% higher rate of cardiovascular-related mortality and nearly a 45% higher infection-related mortality. The association with cardiovascular mortality may relate to higher levels of inflammation or possibly the higher prevalence of heart failure seen in these study patients. And the infection-related mortality may relate to derangements in the immune system or the presence of a central vein catheter. Indeed, those with extreme pruritus had the highest prevalence of catheter use in this study, which may serve to partly explain the higher infection-related mortality seen among those extremely bothered, given the high risk of fatal infections seen in patients with dialysis catheters. With regard to rate of hospitalization, the adjusted rates of all-cause, cardiovascular-related, and infection-related hospitalizations were all about 20% greater for patients extremely bothered versus not at all bothered by itchy skin, while the rate for skin-related infections was about 40% greater, and the rate for mental status change or confusion-related hospitalization was nearly 85% greater, though the precision of these estimates was limited by the low number of events, and so should be interpreted with caution in the setting of this small event rate. It should also be noted that this study adjusted for 15 comorbidities, so these associations are not likely to be explained by the overall illness of the patient, but potentially linked to central nervous system disturbances associated with pruritus or its treatment. Patients with extreme kidney itch were 1.5 times more likely to withdraw from dialysis, which may be a manifestation of the contribution of pruritus to already significant symptom burden in patients on dialysis. Patients with extreme kidney itch were more likely to skip dialysis sessions, which also may be a reflection of the high symptom burden among these patients. Patients with extreme kidney itch were less likely to be employed, and the cumulative symptom burden may also play a role in the difficulty sustaining or seeking employment. Patients were also more likely to experience a prolonged recovery time after a dialysis session, with increasing severity of kidney itch, potentially adding to the psychological burden of kidney itch, and this may contribute to missed treatments or eventual withdrawal from dialysis. It has been shown in previous work, this study showed that progressively more severe pruritus was strongly and monotonically associated with progressively poorer self-reported mental and physical health-related quality of life, as measured by the physical and mental component summary scores, where lower scores indicate poor quality of life. Progressively more severe pruritus was also associated with self-reported depression, as measured by the CESD-10, self-reported restless sleep, being bothered by faintness or dizziness, and being bothered by feeling washed out or drained. Our findings demonstrate how diverse and far-reaching poor outcomes are for patients who experience CKD-AP, specifically those with more severe pruritus, and underscores the need for change in practice patterns to effectively identify and treat patients with pruritus, to reduce symptom burden and improve quality of life, and possibly even survival. This next abstract to be presented at this year's ASN conference is titled Pruritus in Hemodialysis Patients, Course of Symptoms After 12 Months. We have now seen that the burden of CKD-AP in HD patients has been well established, including its association with adverse clinical events and patient-reported outcomes. And while prior studies have focused on a single baseline CKD assessment, longer-term studies of CKD-AP severity over time are limited. So in this study, the aim was to quantify the extent to which pruritus symptoms vary over 1 year for individual patients. In this study, over 8,000 HD patients across 21 countries in DOPPS who had 2 CKD-AP assessments 12 months apart were included. The variable of interest was CKD-AP severity, as assessed by the single question asking about the extent patients were bothered by pruritus in the preceding 4 weeks, with the same 5 response options. Responses were stratified at month 12 by baseline responses, and then we estimated the proportion of patients whose pruritus symptoms worsened, improved, or stayed the same. The proportion of patients at least moderately bothered by pruritus was 37% at baseline, 37% after 1 year, and 51% at either assessment. 28% were at least very much bothered by itchy skin at either assessment, stressing the chronic nature of this symptom. Overall, 43% of patients provided the same response 1 year later, compared to 28% whose pruritus improved and 28% whose pruritus worsened. After 12 months, the majority of patients exhibited relatively stable disease. Among patients not at all or somewhat bothered by pruritus at baseline, 22% became at least moderately bothered 1 year later. Among patients at least moderately bothered by pruritus at baseline, 60% remained at least moderately bothered 1 year later. Our findings suggest that at least half of chronic HD patients were affected by CKD-AP over the course of 1 year, reflecting an unmet medical need. CKD-AP symptoms remain unresolved 12 months later for the majority of HD patients bothered by itchy skin at baseline, demonstrating the chronic nature of the condition. Future research will examine the association between within-patient changes in pruritus symptoms and changes in other PROs. Lastly, we would like to understand the severity and temporal changes in CKD-AP in HD patients via frequent ePRO collection in DOPPS, and here the data collection is ongoing. Currently, we are carrying out prospective ePRO data collection at DOPPS Europe sites at quarterly intervals during an 18-month data collection period, yielding up to 7 serial measurements of pruritus and other PROs. Planned analyses include CKD-AP and PROs, evaluating approaches to measure CKD-AP burden by comparing various CKD-AP instruments and their associations with PROs, longitudinal changes in CKD-AP symptoms, describing within-patient patterns and their association with PROs, and CKD-AP and short-term outcomes, including healthcare resource utilization, hospitalization, and mortality in the 3 months following CKD-AP assessment. Lastly, I wanted to put in a quick plug for a book that is to be published in February 2022, authored by Dr. Hugh Rayner and myself, titled Fast Facts, Kidney Itch, in which we address the fact that kidney itch is common, but often undiagnosed, and even when recognized, it is typically inadequately treated or not treated at all. In it, we describe the problem of kidney itch in detail, document the impact it has on people's lives, review the current understanding of its pathophysiology, and set out an evidence-based approach to its assessment and management. Currently, it is freely available as a course through Karger, for which CME credits can be obtained. This 3-part interactive course highlights the impact of chronic kidney disease-associated pruritus on patients' daily lives with advice on evaluation and holistic management. I have put the link to access this course at the bottom of this slide here. Thank you very much.
Thank you very much, Dr. Suko. And I must say, I've had a chance to read the Fast Facts kidney course that Dr. Hugh Rayner, who is one of our emeritus CI country investigators from UK, and NITI have created, and it's absolutely excellent. Such a great resource, and I think many of you and your colleagues would find it very useful if you have a chance to look at it. So there's a few questions here, and thanks to all 3 of you for your absolutely excellent presentations. And one of them is for Pablo, which is, and I see that I think many audience members that would be interested in this, in that in the US, a lot of nephrologists are not so comfortable in giving such high doses of loop diuretics to their patients. And Do you see that urine volume increases much with using such high doses? And do you have any safety concerns in that regard?
This is a very good question, Ron. And you know, there is a lack of data. And what I can say is very subjective, because we haven't measured the hearing capacity of patients receiving these high doses here in Europe, because we are giving up to 1,000 milligrams a day. And it appears that this patient keeps a greater urinary volume for a long time. But I cannot say that there is no probably safety issue, but we don't see an alert or big side effect. But everything is speculative. I don't have strong and solid data to confirm that.
Yeah. Oh, thank you. Yeah, it was amazing to see the differences across countries in use of the loop diuretics. I think it ranged from 30% to about 85%. Among patients on dialysis less than a year, and across facilities within countries. It's just huge. It's just a really
huge. And I hope this data will change the practice and the recommendation from KDIGO, and because there is nothing in this field.
I was curious if you've had a chance to, and those are based off of DOPPS 2 to DOPPS 5 data, basically 2002 to 2015. Have you seen much change over time, over that time period in use of loop diuretics? Have you guys had a chance to look at that yet?
No, Angelo, probably you can tell us, but I don't think there is big change between the DOPPS phases regarding the percentage of, patients using diuretics.
Yeah, we have looked into that, and we have not found a big difference over time in the loop diuretic prescription.
Okay, well, great. Thank you, Angelo. Nidhi, I was really taken by the findings on changes in over 1 year on how patients, to what extent they're bothered by uremic pruritus. And I was wondering if you've, and this is the first time we've ever looked at this over such a long period of time, and if as a clinician and your experience in this field, have you found those results to be surprising, or that fits pretty much with what your expectation is? And even patients who didn't at the beginning weren't really bothered, and then about 22% were moderately to extremely bothered a year later, and so on. I was just wondering what your, what your impression has been of these first results of, over the longitudinal changes in pruritus.
Yeah, absolutely. Thank you so much, Ron. I think they're not too surprising. Oftentimes when we have patients with pruritus, as they get treated, I see that they sometimes will have an initial improvement, and then as, I don't know if their body just gets used to the therapies that we're trying, the pruritus tends to kind of creep back. And so the fact that many patients are still suffering from it 1 year later, I don't find too surprising. And then what I have seen mostly in my clinical practice is that patients who have been stable, seemingly without pruritus initially, eventually start to develop some pruritus. And this doesn't happen with every patient, but seeing as what I'm seeing in our dialysis patients, it does not surprise me that we do see some patients over time develop the symptom.
Oh, great. Yeah. Well, thank you so much. That was such an informative presentation. And Angelo, just one question for you, because I know we have to get moving on to the other sessions, is that in the work that you did, in some facilities, cinacalcet is given within the dialysis unit 3 times a week instead of daily, taken at home daily by the patient as is recommended by the label. And I was just wondering to what extent, if you had a sense of what percentage of patients in your analysis were taking cinacalcet thrice weekly as opposed to daily.
Yeah, it's around half, maybe a little under half of the cinacalcet users in the U.S. who are getting it 3 times a week at the dialysis session.
Okay, and that really hasn't been examined, has it? The efficacy of thrice weekly versus daily And so I guess that would be, but it is certainly important. Looks like it's a major part of practice here in the US.
Yeah, there's been some small single center studies that have compared the two practices, but certainly nothing on the scale of DOPPS that I'm aware of.
Okay, well, thank you. I just want to thank all three of you for such excellent informative presentations and lots of exciting work going on. So yeah, thanks so very, very much. Okay.
Thank you, Ron.
Thank you,
Thank you,
everyone.
everybody. Bye-bye.
Bye-bye.
Yeah, thank you all, and thanks, Ron. That was a great segment and really nice question and answers at the end. You know, we are so interested in particularly what's